Wonderful. Thank you very much, Ted. Well, thanks so much for everyone for coming. Such a big audience so early on a Saturday morning, and the fun fair's open across the road. So it's great that you're here. You can do the fun fair later. In terms of, I've got a Twitter handle and people are tweeting, but we're in competition against Boris Johnson and Love Island. So we've got lots of competition if we want to get out there and start telling people about the conference. So I'm a geneticist based in Manchester, and I've had a sort of broad training in terms of both laboratory-based work, but really what I'm most interested in is this area that Clara has focused on, in how we actually take forward some of the things that we know and really deliver them in clinical practice. And that's what I'm going to talk about over the next little while. So I sit on an advisory board for a diagnostic company called APIS. That's nothing to do with the work that I'm going to present, and we've been working with a company called Gene Drive. I've got no financial interest in that company, but we've been working closely with them, and I'll talk a little bit about the project that we're delivering together. So Christoph, who's sitting over here, just wants to put up a slide because I want you to interact a little bit with me to answer some questions. So you can get your mobile phones out and log on to this site if you can, and then through the course of the talk there'll be just a couple of questions that will help us just to sort of think about a couple of key points that I'd like to expand on. So if people had a chance to just get that information down, I'll give you a few more seconds. And then we can get going. People are still tapping away. My children are so quick at doing this. I'm so slow with my thumb. It's mortifying, and I put in the wrong letter. But you're doing well. You're doing well. I see you're all concentrating. So you're slow though. Is everyone at it? It'll come up again later. Okay, well, let's move on. Right, is that okay? So this is really just determining in a little of a different way what Clara said. So there are these different phases of research, translational phases of research. So T0 is the discovery, where we find out new things. That could be basic science or finding new genes. You then, once you've made that discovery, the T1 phase is you think about, well, how can we use that? Is that got some application? And then you test that for its clinical utility. Will it really make a difference? And then you take that into clinical practice, as we've heard, and look at the evidence for how that changes things. And then, as Clara mentioned, the final phase is when you scale that up across a region, across a healthcare system, across different countries. So my first question to you is, how much funding is spent on those latter stages of the research phases? So if we just go back to them, on the clinical utility, the assessing it in clinical practice, and the scalability. So of those, what is the percentage of funding that is spent on that? Is it A, 90%, B, 50%, C, 10%, or D, 2%? So Christoph's going to put up the answers. You can vote. It should be on your phones. People, is it on your phones? Yeah, good, good. It's all working. Very techy. Brilliant. So I'll give you a couple of seconds just to vote. And Christoph will hit the button just to see what your responses are, what you think. Okay, so what we've got is the majority of you thinking that 10% of the money goes there. Some people, about equal split between 50% and 2%, and a few people that think that a lot of the money goes there, 90% of the money. In fact, it's less than 2% of the money is spent on that final phase. Okay, and that is why we get into this vicious cycle. So if you're a researcher and you find out something new and interesting, Are you going to take that forward and apply for that very small pot of money that's available to you? Are you going to keep going back into the larger pot and keep discovering new things? And we've ended up with the situation where there is a huge amount of really interesting, exciting data already available to us, which hasn't been implemented, which we haven't taken forward. And that's, as Clara said, this where we need to think about formalizing this and creating a framework and structure around this through implementation science. And so this is a formal framework which allows us, and there are different approaches to this, as has been flagged already, to start to think about how we bring together best practice and integrate evidence so that this can be delivered across a population at scale. So there are lots of factors to consider. Do we have the evidence, and how do we generate that? Are these approaches acceptable to patients and to healthcare providers? Do we have the time to actually introduce these new elements to our work? Or is this just going to be another burden, another stress on already stretched healthcare professionals? Do we have, as we've seen with the rapid exome and genome sequencing in that acute phase, do we have the time to introduce the test, get the results so it's clinically meaningful? Do clinicians, other healthcare providers, counsellors, people who maybe aren't so well versed in genomics, do they have the education and the awareness that these tests are available to them? How do they get them? How do they interpret them? The willingness to pay. Who's going to pay for this? We do have, in different healthcare systems, be it individuals, insurance companies, government-based public systems, that we need to engage with and think about, how is this going to compete with costs for surgery and drug budgets and other things? Do we have enough people in the right places to deliver this program? And can we coordinate things across regions? So in the UK, a number of you will be aware there's been lots of changes, particularly in England, driven by NHS England and the whole 100,000 Genomes project, which there'll be talks around some of the work coming out of that. But that has highlighted some inequalities in England, even though we've got a public healthcare system. Some of the genetic testing has been quite patchy, so it depends in which area that you of the country that you work as to how much access to genetic testing that you can provide for your patients. And so a genomic test directory has been drawn up, which is basically listing out the tests both in rare diseases and cancer, which should be commissioned and paid for. That's a work in progress, and it will go live hopefully next year, but there's a laboratory system that's been set in place to provide that. And it will be very clear, it doesn't matter which part of England that you live in, that you will have access to that testing. And pharmacogenetics will be adopted as part of that. And that's where I'm going to focus the rest of my talk, because I think this is an interesting area where we can learn some parallels around what we've done in rare disease genetics and cancer genetics. So, as you know, there's a session on pharmacogenetics later in the conference, which I recommend you to go with a couple of great speakers. But just to give you an overview, it's focused on using genetic information to avoid adverse drug reactions or try to predict how efficacious a medication is going to be. And so rough estimates are that if you apply this appropriately, you could save up to £1 billion a year just in the UK. Within the healthcare system. So that's some extrapolation of work that Munir Pir Mohammed did in Liverpool, who's been leading a whole program of work on this. So people can have adverse drug reactions both in the community. Most drugs are prescribed in primary care. Over 90% of drugs are prescribed in primary care. And 6% of people coming into the accident emergency department will be there because they've got an adverse drug reaction. 15% of people, once they're in hospital, will have an adverse drug reaction. So, people are better out of hospital than in hospital in many ways. And we're not saying that all of those can be avoided by the right application of pharmacogenetics, but there are some really good examples where applying that knowledge can be really useful. So there's a wonderful organisation, it's international, but it's really led by Mary Relling at St. Jude's with Terry Klein at Stanford. A number of people participate in this, which synthesises evidence from lots of papers, lots of work around pharmacogenetics and pulls that together for clinical guidelines. So there are about 34, 35 of these now where there's a particular drug, genetic interaction that we should be thinking about using in clinical practice. So it's a great place to go. So I'm going to illustrate this concept a little bit around the use of thiopurine drugs. So azathioprine is a drug that's an anti-inflammatory drug. It's used for inflammatory bowel disease, skin disorders, rheumatological diseases, and it's very effective. It's been around for over 50 years. So clinicians feel very comfortable in how to use it. They know how to monitor it. They do blood tests. They know what to look out for. But lots of people have side effects from this drug. They get nausea, feel generally unwell. So about a quarter to a third of people just stop taking their medication. A relatively small number of people get bone marrow suppression, so somewhere under 5%. So that's a really severe adverse reaction where they can get neutropenia, sepsis, and there are fatalities that have been reported. So this just illustrates that azathioprine is a prodrug. It sits over here. It's converted to 6-mercaptopurine and then goes through a number of enzymatic steps to its active metabolite, 6-thioguanine nucleotides. So if this enzyme, TPMT, thiopurine methyl transferase, is missing, what you get is this pushing down this path, so you get an excess of 6-thioguanine nucleotides. So if you have too much of this, it's toxic to the bone marrow. So 90% of people have completely normal levels of this enzyme. About 10% of people have intermediate activity. They tend to do quite well if you give them azathioprine. But 1 in 300 people have absent activity. They carry 2 variants, 2 loss-of-function variants. So it's essentially a recessive disorder. But it only manifests if people are given azathioprine or 6-mercaptopurine. So if you're given that drug at a standard dose, you will get bone marrow suppression. So that was first discovered by Dick Weichelbaum at the Mayo in 1980. Then in the 1980s, some of the genetic variants that underpinned that deficiency were defined by a number of groups around the world. So there are 2 approaches you can take to determine if a person's deficient in TPMT. You can do a genotype-based test, which usually involves about 3 variants. It's different across different ethnic groups, but essentially there are 3 variants that will pick up the vast majority of people who are deficient. Or you can do a phenotype test, an enzyme-based test, which is done on the red blood cells, and that's a little bit tricky, but actually it's a really good test. It's routinely done in the UK now. It's only complicated if a patient's had a blood transfusion in the last 3 months, and then you've got to think about undertaking the genetic approach. But lots of labs do the 2 things. So the technology is there to do this testing. So over 25 years after the initial discovery, this still hadn't been adopted into clinical practice. So I set up a project in Manchester with a number of colleagues to look at this question. Was there clinical equipoise? Should we be undertaking some sort of genetic or enzyme-based test before people had azathioprine? All we had at that stage was a number of case reports, but there was no formal evaluation of this. So we designed a randomized controlled trial for people to be randomized down one of 2 arms, either have the test and then, dependent on the result, they got azathioprine or an alternative or a different dose, or they just had standard of care where they were just started on azathioprine with no testing. And so we recruited 300 plus people over a couple of years, which was not a huge number, and I'll explain why in a minute. The adverse drug reactions were more common in older patients. So the commonality of general adverse reactions weren't related to this pharmacogenetic change, but to other clinical factors. So whenever you're thinking of pharmacogenetics, you've always got to blend it into the overall clinical picture. There had been this contention that patients who were heterozygous, who had intermediate TPMT levels, would have increased adverse drug reactions. We didn't see that. So that was important evidence because, as I said before, patients given azathioprine who are intermediate metabolizers actually do well on the medication. And the one patient who was deficient in TPMT was randomized not to have the testing and did have severe neutropenia and ended up in intensive care. And so even with one patient, the economic analysis showed that this was cost effective. So over the course of that study, over a really relatively short time, we went in the UK from about 1,000 tests a year to over 40,000 people a year having this test. And there were lots of reasons for that. There was this increased knowledge about this testing. There were some clinicians in the UK who were evangelical about every meeting. They would be there telling you, you've got to do this. There were more case reports, presentations, and then national professional guidelines were written by the gastroenterologists, by the rheumatologists, by the dermatologists. And doctors tend to be pretty compliant people. If there are rules there, they tend to stick with them. So that's a really important policy driver. The access to testing, where you could get the test, could you afford it? That was available. The turnaround got much better, so you get the result back just in a few days, so you could use it for clinical decision making. There was another parallel study that was run in the Netherlands by Marieke Koenen, which showed very similar results on a larger scale, so it showed that this was relevant in different healthcare systems, and the cost effectiveness evidence held up. All in all, this adoption, so now TPMT testing is really pretty routine in a number of healthcare systems, that's taken 35 years. So that's a long time from the initial discovery by Dick Weichelbaum for this to have got into routine practice. Let me contrast that with the story of Abacavir. So for those of you who know about pharmacogenetics, Abacavir is the poster girl or the poster boy, because this was a drug that was introduced for HIV treatment in 1999, very effective drug as an antiretroviral, but about 5% of patients get a drug hypersensitivity reaction in the first few weeks. And they get nausea, feeling unwell. Doctors stop the medication, they feel better. A few weeks later, they're given the medication again, and a proportion of those have a catastrophic hypersensitivity reaction, and there have been a number of fatalities. So Simon Malal and his group in Perth in 2004 published a really lovely paper that showed that this adverse reaction was associated with a particular HLA genotype, HLA-B star 5701. And they showed that all of the individuals who had this adverse reaction carried this variant. So in the UK, and in Australia, there was rapid adoption. They saw this evidence and thought it was so compelling that they adopted. But lots of countries around the world didn't. They didn't want to take on testing prior to prescription. And so GSK ran a randomized controlled trial, 1,800 patients. People were randomized either to have genetic testing or not, and on the basis of the genetic test, got Abacavir or a different medication. And overnight, the adverse reactions were completely removed and it didn't happen. And within weeks, the FDA, MHRA, EMEA had mandated that you have to do genotyping before you prescribe Abacavir. And so now, from the original discovery to the RCT being done and adopted into clinical practice was 4 years. That's a huge contrast with the TPMT story. Now, it's a more defined group of clinicians, so it's HIV doctors that are using this medication compared to azathioprine, which has got a much broader remit. But the evidence base was really strong, and then that mandating in regulation made it absolutely key that it was going to be adopted. So I'm going to tell you a little bit about now a project that we've been working on. And if you were here last year, you might have already seen a little bit about this, but this is just to give you the background. So we're interested in Gentamicin, antibiotic that you know is used in lots of people for the treatment of gram-negative infections. And so here's a sketch of a cartoon of a bacterial cell, and within that there's a mitochondria, and within that is the ribosomal part, and there's essentially a receptor in there within the 16S subunit, which the aminoglycoside binds to in the bacterial cell and kills the cell, and that's how it treats the infection. In normal human cells, we've obviously got mitochondria, we've got the ribosomal subunit, but the receptor within that is a different shape, and so the antibiotic doesn't bind to that, and normal healthy cells are absolutely fine. And that's true of people, about 499 people out of every 500 who carry this particular wild-type variant, M155A. 1 in 500 people, however, carry a different allele. They carry a G at that position, and that changes the receptor. The antibiotic binds to it, and 1 in 500 people exposed to gentamicin will go severely, profoundly, irreversibly deaf, particularly if they're very young. And so this isn't great implementation science, because he's got his sleeves down, he's wearing a tie, and he's doing all sorts of naughty things. But it's to illustrate that we wanted to do a neonatal study. So the problem is that since 1993, we've known that individuals with this variant develop profound, irreversible hearing loss. And every year in the UK, there's about 90,000 babies that go onto the special care baby unit, onto NICU. And they're pretty much all given gentamicin to cover against sepsis in accordance with the NICE guidelines. So these are UK-based guidelines. So essentially, you're exposing, if it's 1 in 500 babies, 180 babies a year are going deaf because they're getting gentamicin. Now, that's not always picked up, because people say, well, they're premature, they've got other illnesses, they've got a whole range of other things. So it's not actually teased out. But clearly, there are a significant number of babies at risk. So what could you do? You could give a different antibiotic, but there's concerns that you'll get antibiotic resistance if you give an alternative to gentamicin. Or you could do a genetic test on these babies and test them, but routinely testing for this takes a couple of days, and you need to give the antibiotic within an hour. So what we've done, working with GeneDrive, is we developed this asymmetric PCR-based test using a Melt curve analysis, so you get good discrimination between the variant and the wild type, and then that separates out a probe which dissociates at different temperatures, and on a point-of-care test based from a buccal swab that you take from the baby, you can get a result at the bedside using this very simple technology. So we've been able to show that that works on buccal swabs as well as DNA taken from other places, so that's very easy to get from the baby very quickly. We've also tried to reduce the time down from 50 cycles down to 40 cycles, so you can do it in about 40 minutes, which is within this window of opportunity. So this is what John McDermott, who's a clinical fellow working with us, presented last year, that we'd got to that point, that we'd shown that this was a rapid test that we were able to do in the clinical timeline, gave us good results. It was very simple. It's got one button to press. It's right next to the baby, and you can use a buccal swab. And cost-wise, we thought that at that stage it's going to save money, because the care of children with severe profound hearing loss is really very significant. So that was great. So John won a prize, which is all good, but that only took it to that point. So we needed to think about, well, how do we actually take this point-of-care test into clinical practice? And so we designed a project called the PALOH study. So the PALOH study is an implementation science study. It's a feasibility assessment. And there are a number of things that were challenged to us. What was the challenges of taking this into the acute setting? You've got sick babies, lots of things happening. You want to introduce a genetic test into what's already quite a fraught and challenging environment. What was going to be the right trial design? So should we do a randomized controlled trial? And there wasn't the clinical equipoise. I couldn't justify not testing a baby if I had that technology available to me. And so the only reason we're not doing it is because we've not had that technology in place. Could we make the assay better? And then how are we going to roll this whole project out? And so the project has been designed so that we optimize the assay. I'll tell you a little bit about that. We get all the protocols in place, we train staff, and then we run this project over 2 units, one in Manchester and one in Liverpool, over a 6-month period, and every baby coming onto the unit will have the test, and then we make the decision about their medication at that time. And we determine whether it disrupts normal clinical practice, or actually do things work as they should do? And so the first thing about optimizing the test is about getting lots of positive controls, lots of negative controls. This variant is found across all different ethnic groups, but it may be that the background is different, and that could disrupt the assay. So we needed to make sure that was in place. We needed to ensure that it worked for neonates. So we tested it on adults before, on samples that we got from adults, but there could be amniotic fluid in the mouth, or there could be breast milk, or there could be meconium. Were they inhibiting substances? So we needed to think about those challenges. We've switched to a new technology. So we've moved away from PCR. We've moved to a technology that some of you might be familiar with. It's been in place for about 20 years, called LAMP. So this uses a polymerase, but uses 4 primers instead of 2. And because it's at a single temperature, it's allowed us to drop the time down to 22 minutes rather than 40. So that's a huge difference. That's absolutely transformative for us. So the next question is, get your phones to the ready. This is a feasibility study. Does it require ethical approval? A, yes. B, no. Or C, I don't know. I feel like that guy is it A Millionaire or whatever the program was? I don't have his money, unfortunately. Right, got your phones to the ready. Let's see what you think. Right, okay, so you think it requires ethical approval. So we had a lot of discussion through our data monitoring committee about this, and there was really mixed responses, thinking this is an implementation science program, and so shouldn't require ethical approval. We went to the ethics committee, and yes, we do need ethics approval. And their reason was because our intervention results in a change in routine clinical practice. So that was the motivation behind that. So as we were making this change to clinical decision-making on the basis of this new assay, they dictated in discussions with the MHRA that we needed CE marking. So this is regulatory approval that we needed to meet a certain set of criteria. At the moment in the UK, because of the way the new in vitro diagnostic directives coming in, we're able to self-certify, so generate all the evidence, and then the inspectors can come in and say, actually, everything all looks fine, that's okay, rather than actually waiting for full CE marking. But one of the challenges around CE marking is that actually, as you apply for that, you use the information that you've gained in the clinical space. So if you can't do that, it's going to be a bit of a catch-22 in the future if you have to have CE mark something before you actually are able to take it into clinical practice. So now this is a research study. What do we do about getting participant consent? Do we do that prospectively before we undertake the assay? Do we defer that, take retrospective consent, so we do the test and then we ask the parents for permission to use their information afterwards? Do we opt out, so actually we take it that it's presumed consent unless a parent actively says, no, we don't want to participate in the study, or you don't know? So it's A, B, C, or D are your options. Right, what are the scores on the doors, as someone once said? Okay, that's really interesting. So a number of you saying that you think that we need to go for prospective consent, a small number for deferred consent, and then a significant group for opt-out consent. So I'll tell you what we've done. We've gone for opt-out consent, okay? And the reason for that is that you've got a very short window. In the acute setting, there's lots of experience around studies with myocardial infarction and stroke in adult medicine, but also increasingly in neonatal medicine, where you have to do something quickly. So there isn't time to sit down with the parents, with the mothers often just given birth, the father's either there or not, and so trying to coordinate them, and when they've got a very sick child, talk to them at that point is going to involve a lot of challenges. And the situation in this study is that the worst that can happen is that the result is wrong. And if the result is wrong and we give the baby gentamicin, that's what would have happened anyway. So that's the default position. So deferred consent, we talked a lot about this retrospective. Should we go back after a day or two and speak to the mother and get consent there? And our patient support group, which I'll talk to you about in a second, were absolutely clear that they felt that was a really bad time. You know, if you've just had a child who's very sick and there's lots going on, talking about a project which actually you've already done the test. Why wouldn't you want your child not to be deaf if that could be avoided? It was quite a vulnerable time and quite a challenging time to seek consent at that time. So we've created a situation where every parent that comes onto that unit with their baby gets an information pack of all sorts of information. We've got a very small little sheet just telling about the project. If you don't want to participate or you want more information, you can contact us. And that's been applied across a number of acute neonatal projects now in the UK, and Nina Modi, who's the chair of the Royal College of Paediatricians in the UK, led a programme around this opt-out approach. The challenge for her was that they took exactly the same protocol, gave it to 12 ethics committees, and they got very different responses, and it was only approved in 9 of them. And so there needs to be some coordination across ethics committees in how they address these sorts of challenges. So I mentioned to you about having that patient-public engagement. So we've got 2 lay members who are active members of our research study team. One of them's a risk management expert, which is great. Another woman has significant hearing loss herself. They formed their own group with a group of mothers who've had children on the neonatal group. They've set up a Twitter site. They've got a Facebook group. And they're really actively involved in helping us to design the information that's given out and talking about the experience of being a mother in that situation where you've got a very sick child. Current clinical practice is that the antibiotic should be given within an hour. So one of our measures is introducing the test. Does that slow everything down? Does it disrupt everything? So what we wanted to know is how often are babies getting their antibiotics at the moment within the hour? So do you think that every baby gets their antibiotics within the hour? So the ones that don't receive it, that's 0%, okay, so that's A, all right? So if you think every baby gets their antibiotic in an hour, that's A. If 10% don't get their antibiotics in an hour, then that's B, C is 33%, and D is 50%. Okay? So if you think that 10% of babies don't get their antibiotics in the first hour, that's B. Okay. Let's see what the scores are. Right, you're good at this. Right, that's the last one, you've done well. So 33%, yeah, a third of babies don't actually already get their antibiotics in the first hour. And that's often because you can't get the cannula in, okay? You can't secure IV access. And so if we introduced our test and we hadn't measured that as the baseline, we would have thought, actually, we're disrupting what is already a really good standard practice. So that's really important to make sure you really understand what current clinical practice is before you intervene in that. And so we also needed to make sure that our point of care test has the right information put into it. It's got the baby's name, it's got their number, it captures all that clinical information that then feeds into either a paper output or an electronic output. And that's why we've got the study running in different places, because it challenges some of those different things. We can only start the study when 80% of the staff are trained. So we need to make sure that every baby has an assigned nurse who takes responsibility for doing the test and actually getting the result and acting on it. As Clara said, it's no good if you have this information and then it's not acted upon and you don't take it through. So the next part of the study is this implementation that every baby is going to be tested, and that's going to be starting just a little bit later this year. The economic analysis is going to be a cost consequences approach that's folded into this, and then we're also doing a qualitative study where we're exploring the preferences of healthcare professionals, of parents. We're using postcards, structured or semi-structured interviews that Rona McLeod and Fiona Ulf are leading on, and so trying to understand the barriers to adoption. And then, of course, as clinical geneticists, if you identify a baby with the variant, we know it's a mitochondrial variant, so you know straight away that mum's got it, or the siblings have got it, all mum's siblings have got it, and so you need to think about how do you support those families, What information do you give them because they are at increased risk of hearing loss later in life? I think it's absolutely key. Right at the beginning, we decided that we wanted to have a stakeholder group to ensure that the project doesn't stop just at the end. And we make sure that this can, if it all works, be scaled up. And so we've got a stakeholder group which is chaired by a member of the National Children's Charity for Hearing Loss in the UK, but we've also got one of the lead commissioners for genomic implementation at NHS England sitting on that group, and an implementation science expert. So Paul Wilson works with us in Manchester, and he's the person that's created the framework about thinking about how we pull all that information together. So what I hopefully have done is illustrated, one, the importance of thinking about this, but then drilling down into some of the specifics which hopefully you feel that you can extrapolate into your own areas of work. I think that sharing our approaches and our experience of these types of projects will help to adopt more and more in the future. So we've considered the emergency setting. You know, there's an area where geneticists generally haven't really been working at that point in clinical practice. So I think that's a really new and interesting, challenging space, where often there's lots going on and it's a highly charged clinical scenario. We're working across different departments where there isn't necessarily a great knowledge of genetics in the acute neonatal setting, especially amongst some of the nursing staff in those places. So providing the right support is really important, training them and ensuring that all the data is collected appropriately, and then going through all these regulatory processes to make sure you've got all that in place. So hopefully, through that talk, I've given you a sense of just some examples just in pharmacogenetics where you have delays to adoption, and then how that can be improved and who you need to bring on board to ensure that that happens. Just like to thank all the people who have worked with me on these various projects and the people who have funded me. And I'm sure Clara and myself will be delighted to take questions and have a discussion now. Thanks so much.